asked me to just say a few words about this this seminar series, which is going to be every week at this time, unless it gets canceled for a holiday or some special event. We're kicking it off today. We thought we'd wait until after the CIHR rush, and of course after the move, before starting these. So this is the first one. Before introducing, I'll just say a few things, unless Dominique wants to either correct me or add to something I'm going to say. I was asked to stand here because the camera is there, and that enables people who cannot be here to. This is going to be live, and for a short period of time afterwards, like an hour to a couple of hours. No. But how long will it be available on YouTube?
Forever.
Oh, it's up to the PI. How does he or she do that? So they just tell you that I want this to be perpetuated for my grandchildren, and you do the rest? Okay. But in the meantime, people who cannot be in the room have the option of watching live on YouTube, for sure. And that it doesn't matter whether they're the General or the Vic or Purvis Hall or wherever they are. Okay. There's a link. And for people who want to stay in their offices here in the core and want to ask questions, I guess that's the reason for asking the speaker to spend. Do we give her lunch or anything like that? Or no such luck. But she can go into the kitchen. Yeah. And cook. And people who are either too shy to ask you in here, or people who don't want to crowd in, and it is a good crowd today, but are, let's say, looking from their offices, can ask you questions, which they can't do right now given the technology from their offices. So I'm going to pass. Any questions about the seminars? I want to say one more thing, sorry, and that is there's a meeting, you'll be interested in this, and most other people will too, but you'll be less surprised. So there's a search committee for the new director or the dean of the School of Public and Population and Global Health, and I'm on the selection committee. And we were talking. We had a meeting last week with the chair of the International Advisory Board, who was here on a visit from Duke, and we were talking about there's a group of people on the search committee from the Social Sciences Medicine Department, SSOM, who have not agreed to be part of the school. And one of the reasons is, they said, is because they're afraid that their qualitative research, there are several reasons, and it's a small group, and they're afraid of losing their identity and getting drowned out by all the epidemiologists and biostatisticians. But they thought that their qualitative methods would not be sort of welcomed in a large school of population and global health. And it just so happens that we have a few qualitative researchers here. Amrita's not the only one. But I thought it was interesting. I think it's just a coincidence, but that I did say there that we have several here in core, and I thought it's an interesting coincidence that our first one is by qualitative researchers. So I won't say anything more about Amrita, who I really don't know very well, but I passed her office a few times, said hello. And I'll pass the mic to Manu Pai to introduce Amrita more thoroughly, seeing our research and how it fits into.
Thank you, Mike. Welcome everyone for the first core seminar. It's a pleasure to introduce my colleague Amrita. Amrita came to us from Toronto. We're not going to hold that against her. She did her PhD there at UFT and her MPH from Columbia and a postdoc at Columbia before coming to McGill. She's now an assistant professor in our EBOH department. But like Mike said, I think her skills and talents really are more suited to a School of Public Health, which we will be very soon. She is a qualitative researcher, works on social behavioral issues in TB and HIV. And she's done a lot of work in South Africa on the TB-HIV epidemics and how patients navigate the complex pathways, why they are not adherent to TB-HIV medications, the contrasting cultures of how TB and HIV programs take care of patients very differently. And she also has a pharmacy degree, which also made her exceptionally well suited to do this project that we got funded by Icc Impact in India on how to engage pharmacists to detect TB early in India, which has the world's largest TB burden. And then more recently, she was successful in getting a Gates Foundation grant to do TB work in South Africa, as well as a Steinberg seed grant from Global Health Programs. So despite the spectacular implosion of CIHR in the recent past, she's done well with non-CIHR funding, which I think is particularly helpful in today's climate of funding in the country. So Amrita, very happy to have you present the seminar.
Thanks very much, Madhu. Thank you. It's a pleasure to be here, and thanks for the warm introductions. I'm excited to be presenting this work and being a part of the first core seminar. Now that it's going to be on YouTube, I'm very excited because my son is going to watch. Yes, my son. There's actually hope that my son will actually log into me instead of, Ninjago or some other equally exciting channel to watch. So I'm going to, as Madhu mentioned today, I'm just going to spend about half an hour or so and hopefully leave a good amount of time for discussion about a project that we embarked on in 2015, the Icc Impact Grant. That was is a center of excellence that's a collaboration between the Tri-Council group as well as an Indian sort of network of excellence. It's a really nice collaborative agreement that spans all the disciplines, not just the social sciences and health, but also the natural sciences, and sort of supports funding that spans these various spectrums. Okay, so the context. India, as Madhu mentioned, has one of the highest burdens of tuberculosis, and I know many of you who are in TB don't need to really read the slide, but really we have over 3 million cases there, and about a third of them are missing. In other words, they're not diagnosed properly, they're not notified to the National TB Program, and so we're not really sure what happens to them in terms of their treatment and effective management. We have over 200,000 annual deaths a year attributed to TB in India, and most of these cases are pulmonary TB cases. So the most common symptoms, fairly benign in terms of chronic cough, but then you also see these other sort of markers of TB, like night sweats and sometimes bloody cough and weight loss. So this is sort of I just want to build up a little bit of the context in which this happens. The main drivers of TB in India really can be fourfold, I would argue. And the first one is really very, very poor social conditions. So you're looking at a place that has very, very high rates of poverty, overcrowded housing, poor work and living conditions, high rates of malnutrition, and other comorbidities or behaviors that might perpetuate or trigger somebody to develop active TB if they're exposed to the latent bacillus. For example, high rates of smoking. There is a lot of diabetes. You are seeing a higher rate of NCDs, and there is a substantial burden of HIV. The proportion is not very high, but the weak health infrastructure is something that really perpetuates delayed diagnosis, delayed onset of treatment or correct treatment regimens. You can see how people are treated in the public sector. It really is very overcrowded, and there is really poor, weak steps that you need to sort of undergo in order to get properly diagnosed with TB and then move on to treatment and then finally complete treatment. Biggest drivers, the unregulated, very large private sector in India. So about 80% of Indians, rich or poor, are going to visit a private physician or a private practitioner, and that could be any one of these. So there could be former qualified doctors, where we have nearly 900,000 of them, Ayush practitioners who are more sort of informal, clearly practitioners who practice on the peripheries of an MBBS or MD sort of degree, and any other acronym that you can put. They're highly trusted in from yoga, Ayurvedic medicine, homeopathy, and other sort of various traditional healing methods. Very, very strong piece of the Indian private sector. And then, of course, we have the private pharmacies, and you're going to see that there are like over 800,000 of them in the country, really a dime a dozen. What happens is that people navigate this in a constant sort of pluralistic pattern, going back and forth between various providers. Whereas here, our sort of pathway to care is fairly regulated. There, it isn't. And a patient, as much agency you might think she or he may not have in a country that's so poor and weak in infrastructure, patients actually practice a lot of agency when it comes to deciding where to go, who to see, and it takes nothing for them to say, I don't like what this doctor is saying, I'm going to go to the next one down the road and get a whole new treatment regimen and diagnostic decision making. pathways to care are for TB patients are very complex, and this is just taken from a paper that came out a few years ago where they actually followed patients, to see how they eventually got diagnosed with TB. And literally, it is this convoluted. This actually makes it look quite pretty with the straight arrows, but when you take it in a whole, there's really no linear pathway. It's all over the map, and this is the reality of how people navigate the healthcare sector in India. So I'm going to focus on pharmacies for a number of reasons. Some of it is because I am trained as a pharmacist. I'm from India, and I was very, very keen to sort of mix the two and do some work in this area. And Madhu sort of gave me the opportunity to apply for this grant and get it. India has nearly 1 million pharmacies. Literally, they're at every corner. And they happen to be the first point of care for about a quarter of all patients that have these typical symptoms of TB, so somebody with unresolved chronic cough. And we know there's 2 sort of systematic reviews that have been done among patients who eventually got diagnosed with TB. Why? Because pharmacists are a dime a dozen. They're everywhere at every corner, very accessible. There's no fee, and they're quite trustworthy, right? Patients have quite a good relationship with their community pharmacist often. So literally the same reasons why we go to the pharmacy around the corner here if we're having a little bit of cough or cold or symptoms that we're not quite sure what to do with and we feel are not really severe enough to go see a doctor, we go to the pharmacy. So the same happens in India. The problem in India is that most pharmacies there are not regulated. Okay, there's literally no professional stewardship, no accountability for the most part. So they're seldom run by skilled pharmacists, by trained professional pharmacists. There might be a license that you'll see somewhere in the back corner, but for the most part, the person that actually runs the license is sitting in another city or another country. Very poorly regulated. There's a strong business ethic. This is how pharmacies are run in India. It's a business model. They want to make money. And this is, of course, supplemented and sort of boosted by the fact that patients that visit a pharmacist want to buy drugs, right? So the supply demand is very, very strong and perpetuates this culture of purchasing medicines that you may or may not need. In the Indian context, not only are you going to get a cough suppressant or something like an inhaler to help resolve some of your symptoms, you're also going to get over-the-counter antibiotics, which are very freely sold over-the-counter. Things like ciprofloxacin, clavulin, you name it, right? You can just get it over-the-counter, no problem. Often you're just getting 2 or 3 days supply, and then there's this back-and-forth system that happens. The consequence, of course, is that one of our doctoral students who's now sort of moved beyond Dr. Srinath Satyanarayan, who many of you may already know, he did some work in India and has discovered through his sort of studies that fewer than 1 out of every 5 patients who eventually is diagnosed with TB is not referred to the appropriate medical care, right? So you're seeing a very high diagnostic delay, risk of death, transmission, you name it, and risk of drug resistance if you're given medicines like ciprofloxacin without the adequate sort of multiple drug regimens that you would normally need for TB. So can we harness this trust, this accessibility, this no-fee system that pharmacists run on to actually use them to enhance the detection of TB? So this is a paper that we published a year ago where we sort of did a brief systematic review, which is now becoming a more formal systematic review that Danielle and Anita are working on with me and Madhu. And we basically kind of just thought about what are the various roles that a pharmacist can play in the TB care cascade. And really, this is the status quo, right? They're drug dispensers. We're pill pushers. That's sort of the basic bread and butter of what pharmacists do. But there's several other things that they can do in terms of surveying OTC sales, observing treatment, or at least supporting patients with treatment who are on TB treatment, engaging with the private sector, regulation, and triage and referral. So the Icc Impact Study really focuses on these 2 pieces, on how to sort of engage pharmacists in the care cascade by capitalizing on the fact that they could be used as a way to liaise with the private sector, and they could be used to triage and refer symptomatic patients. So the Icc Impact Study, the goal is to engage chemists or pharmacists to refer TB patients for a screening test and or a doctor consultation with the overarching goal of improving early case detection. Right? And the study was run in Patna, which is sort of a northern state in India. For those of you who may not know much about India, this is literally one of the poorest parts of the country. If you see a BBC documentary with people walking all over the road and animals all over the place and literally no infrastructure, this is likely where it was shot. This is not Bombay, this is not Delhi, or some of the other sort of nicer cities in India. This is a very, very poor, literally in our language we say Bimaru state, which means a sick state. It's just not healthy in many ways. This was a very collaborative project. So Madhu, of course, has been working in India for years and has developed an extensive network of colleagues and research partnerships that we built upon. And so this is just some of the people who helped make this work happen. And so how did we actually accomplish this goal of engaging chemists or pharmacists in India to achieve early case detection? So one, we really used the literature, as I think all of us do when we embark on research. But we focused on a few key areas. And the first thing is that the private sector is really key to TB control and management efforts in Southeast Asia. We also realized that e-health can be something that can be capitalized on in terms of making things efficient and improving the quality of care, but they need to be done in the context of the communities in which they actually implemented. Right? So not sort of the fancy e-health solutions that we would all love to implement, but you need to tailor it to context. Private pharmacies, if you're trying to engage people that are working in a business model, you've got to reach them in that model and not the public health model. These pharmacists that we're working with in India, for the most part, are shopkeepers. So their ethic, their mindset is very different from what you might see at a physician in India or a physician in Canada or a pharmacist in Canada. We nested a study into a broader project and local momentum. So the Universal Access to TB Care, or the UATBC program, is a public-private initiative between World Health Partners, our Indian collaborator, and the government of India. And it's sort of a network. What they do is they've networked about 1,500 providers, chemists, labs, and doctors in India, and specifically in the city of Patna, and engaged them in TB control and management sort of measures. So they've sensitized them to what TB is all about, what are the more standardized ways following the WHO and Indian guidelines on how to manage TB. So trying to sort of engage with the private sector in a way that would be meaningful and sustainable, rather than just say don't go to the private sector, because that's not happening in India. We also realized there was this ongoing media campaign where they're using like one of the most sort of popular Bollywood stars to promote TB and awareness about TB in the community. So we sort of piggybacked on these efforts. The UATBC project, it engages, as I mentioned, over 1,500 pharmacists, doctors, and informal providers, or sort of Ayush practitioners, as I mentioned earlier, in the city of Patna. And there's a complex referral pathway, but the idea is that eventually the goal is to notify TB cases to the government program. So within this UATBC project, I'm not going to go through the slide in detail, but I would like you to focus on the points there. Private doctors can manage TB using the government algorithm, basically that'll follow guidelines accepted by the NTP, the National TB Control Program, which in turn are guided by the WHO. Ayush practitioners, or informal medical practitioners, can order X-ray tests and sputum tests, and eventually they need to refer these patients to a doctor to actually get diagnosed with TB. Pharmacists can refer patients to doctors if they find that they have TB-related symptoms, and eventually, if this patient is diagnosed with TB, he can dispense TB drugs. And tests and drugs under this system are completely free, as they would have been had a patient gone to a public health clinic. So our goal for this study was really to see, can pharmacists do more than just that, right? They're referring patients to doctors, but can they do more? Yeah.
Just to clarify, all that stuff was done under the context of this other project, like the IUC?
Yes. This is sort of the baseline project on which we piggybacked and nested our study into.
So all these Irish professionals were trained for estimates as well.
Yeah. Yeah, so this is, I wanted to set this up because the idea, what we propose is not so novel when you take this context into place, when you sort of consider this context, but it is novel in the broader scheme of how pharmacists have been engaged to date in TB control. So sort of the baseline pathway, if you can imagine, what we began working with is a patient with cough will go to his or her chemist or pharmacist, and then eventually, we'll go back and forth, we'll try a few antibiotics, the circular pattern. Eventually he or she may get referred to a doctor. Eventually the doctor might decide to order an X-ray, thereafter a sputum test, and thereafter, if the patient is notified, they come right back to the pharmacist to get their drugs. Okay, so this is sort of the baseline pathway that we were going with for the types of patients who first visit their pharmacist as opposed to any other practitioner. In 2013 to 14, we knew that from the UATBC program, the chemists that they had already engaged, about half of them had in total referred 97 people with symptoms of TB to the doctor. So this is extremely low in the Indian context. We know that every year we have about 2 to 3 million cases diagnosed. This is a very populous part of the country. This is a gross underestimation of the numbers of people who would normally walk into a chemist shop with these classic TB symptoms and who could have been referred. Very few of them had actually been referred. So our goal for this study was to really bypass this one piece, right? One piece of the pathway. So we wanted to give pharmacists the capacity to order a lab test, a screening test, before referring the patient to the doctor. And we wanted to see if this would propel sort of rates of referral and thereafter propel early case detection. Mm-hmm.
I just understood the denominator on the previous slide.
Mm-hmm.
How many were referred? Go back.
Mm-hmm.
97 pharmacies had referred 322 pieces of medication to the doctor.
So there were about 700 pharmacies engaged in this program who had been said, like, please do this, please refer patients who have these classic TB symptoms. I didn't put a denominator because, frankly, it changes. People come in and out of the program, but it's between 600 to 700. So it is. I mean, this denominator issue we'll get back to in a little bit. And over this course, because every patient that gets referred by a pharmacist is given a little slip. And so that's how we know that they were referred by a pharmacist. And it's through an E sort of referral system that I'll talk about in a moment. So that's where these numbers come from. So this is not like this was the only baseline data we had to work with. And so we wanted to train about 100 pharmacists to refer patients, not just to the doctor, but before that to also refer them for an X-ray and see if that kind of made any difference, right? And so this is sort of the UATBC model that we were working with, and these are the new things that we presented as part of our study. So in other words, pharmacies were still dispensing TB drugs. They were still referring patients to the doctor, but now they can actually refer patients for a chest X-ray as well. And then they can get an incentive for that referral, the same way an Ayush practitioner or a doctor would get the incentive for these sorts of referrals. We also allowed pharmacies to get SMS reminders, awareness posters to sort of ensure that patients in the community were aware that this was going on. And then we allowed pharmacists to give feedback because this was the first time we had actually engaged pharmacists where there was a two-directional conversation, and we weren't just asking them to do an intervention, but really actively seeking their evaluation and feedback on whether this was acceptable or not. So I'm going to get into this in a few slides, but I wanted to give you the overview. The whole UATBC model was already quite digitized. There was an ICT call center that any provider, an Ayush practitioner, doctor, or pharmacist could call into and sort of get this immediate electronic drug voucher number that he or she could then give to the patient and go on for the next test or treatment that he or she was due for. And this is quite an efficient, elaborate enterprise. There are about 20 people working at the call center. Most calls are answered within 45 seconds, and most calls are completed within 45 seconds as well. So the whole thing is about a minute and a half. The person on the other end takes all the information that's necessary for the patient and then generates a voucher number that the patient can use to access a free test or a free treatment related to TB. So it's pretty sophisticated when you see it, and quite well run, I have to say. We also used a very participatory approach. So 3 months before the project was actually implemented, we went and did a 2-week field visit. We did a situation analysis of what is the intervention model that's most likely to fit. In that context, we had interviews with a bunch of pharmacists on the ground to ask them, like, what are the regions in the city that will most likely be amenable to something like this? What are the types of pharmacists, what are the barriers that we might face in terms of implementation? And how can we fit this into the local context? So we had a lot of brainstorming sessions, and eventually, of course, we got all the approvals that we needed from the MUHC and the UATBC World Health Partners program. We really tailored the project, I think, to pharmacies' realities. So they were actively involved in developing the vouchers, basically, that we used for them to triage and refer patients. We used them, we used their input on any posters that we displayed to make sure that they were sort of readable by people who had low levels of literacy. We also made sure that the forms were very easy to fill out. We sent them text messages to remind them how to use the system, that if they see patients with these classic TB symptoms, call the call center, and then every month we would actually send them what their performance was as an incentive to let them know that, they've done well, or perhaps they could do better in terms of their referral. We did tailor this to 2G networks. It would have been great to go on an app, but really our survey of pharmacies in the area showed that most of them just use 2G phones. Why did we pick an X-ray versus any other type of a test? For two reasons. If you look at this, if you look at the most common ways to sort of diagnose TB, aside from the clinical diagnosis, you have the sputum or gene expert test, and then you have the radiograph, which is sort of the first screening, one of the first screening tests. Normally, you would go with this because you see the 90% sensitivity, 99% specificity with gene expert, for example. The problem is that, of course, these tests are quite expensive in India. Even if they're covered by the UATBC program, they're perceived as being quite expensive. There's also very few facilities that offer it. So we ended up going with the X-ray because it's far more sensitive to just picking up at something, like some sort of an abnormality that would warrant a patient go see a doctor. And they're available in many, many labs, so much, much easier accessible to patients. And they're actually more acceptable even in terms of you just have to sit on the desk on a table and get x-rayed as opposed to producing sputum. And so this was something that was decided in consultation with the pharmacists. We also know that in this part of the country, this is the first test that all doctors use to diagnose TB. This is not the WHO algorithm, but this is the reality.
You mentioned skin tests, though. Is that because of vaccination?
Yeah. The MAN2 test is not used to diagnose TB in India, as far as I know, because everybody's exposed. Active. Yeah.
So does so they're not overlapping? I understand that the cases that have latent infection that don't have active TB, but it's very expensive. Are they not used?
Active TB can render the.
I understand that too.
Negative. So we don't use it here either. If active TB, we always build the X-ray.
And there are good reasons for wanting to only detect active cases.
Because they're not even going to do that.
Yeah, the priority is really active. We're nowhere near looking at latent. Ideally, we would, especially as a prevention tool, really. But the burden is so high that the focus is really on active cases. But that's a fair point. But this is really one of the reasons why we also wanted to get pharmacists to do this, and then the doctor will take care of this piece. Another reason is this is the first time we're actually putting ownership in the pharmacist's hands to run some sort of a screening test. It hasn't been done before, and we didn't really want to give them this. We'd rather give them a test that's very sensitive and pick up all kinds of abnormalities, including but not limited to TB. We didn't really want to give them this and start having them prescribe medicines and things like that based on the result. So the e-voucher that was developed with pharmacists, with about 12 pharmacists that we had consultations with, really the focus was that they need to refer patients who have unresolved cough for at least 2 weeks. That was the biggest sort of piece that they had to check off. The exclusion criteria, we had a strong list of exclusion criteria that you would use pretty much in any setting in terms of who not to x-ray. So that was what we did. Cough that was less than 2 weeks, if they were pregnant, if they were, kids, recent history of an x-ray, any history of TB, if they were already seeing a doctor for any reason, if they had any sort of a chronic respiratory condition, and of course if the patient doesn't want this. And remember, all of this is happening within about a minute. That's about all the time the pharmacist can have. If you ever visited a pharmacy in India, there's no private section in the pharmacy where they can chat with patients. This is all happening very quickly. Everybody's around listening, so working with that context and seeing what is the most useful and relevant implementation science method that you can apply to get the project underway. We did have an incentive structure. So this was unique to Patna. If we were to do the study in some other parts of India, we wouldn't necessarily use this incentive structure. But every other provider in the broader program that the study was nested in was getting incentives for all kinds of referrals. So we sort of had to mimic it. They were getting $2 for an x-ray that was actually completed by a patient, $1 for actually completing a doctor referral, and $4 if the patient was ultimately diagnosed with TB and notified on account of their initial referral. So this was very comparable to what the doctors and Ayush practitioners were getting. Just to let you know, in the public sector, doctors get about $10 in order to successfully treat a patient with TB. So it actually falls a bit less than that.
Profit would they make just dispensing?
Yeah. That's a really good point. So usually we ask them like what a 3-day course of antibiotics that they would normally prescribe plus a cough suppressant or something like that would cost, and it's about 75 rupees, which is about $1.50. So that's another reason why we wanted to give them an incentive that would potentially compensate for loss in OTC sales. Unfortunately, we do not know, and that's going to be a limitation. We don't know if it actually changed over-the-counter sales because there's no records kept of these things. So we don't know if that behavior changed. But from focus group discussions that I'll talk about in a minute, they sense that probably they sent patients less often back to their homes after repeated trials of antibiotics having failed. So we probably made some dent there, but it's not measured. And we did a lot of training, troubleshooting, and quality checks. So this was huge. We closely monitored the pharmacists, did a lot of refresher trainings. We had field officers going and visiting them. So each pharmacist was usually visited at least once to twice a week and called once to twice a week as well. We did quality assurance calls, like randomly. The ICT call center would call patients who were referred for an x-ray to really identify, did they have those symptoms? What did they have? What was the process with the pharmacist? Just to identify, to sort of report against any sort of misuse of the system.
So, also ask if they've seen
If they were, no.
So when a pharmacist refers for chest x-ray, he doesn't give them any medication?
No, he could. So in this form, actually, this right here, there's a section right here. If they tried any other medicines and which medicines. So we haven't gone through all of the vouchers, but we do have quite a few vouchers that actually say, amoxicillin for 3 days or something like that. Because what we did during the training period, we made it very clear to pharmacists, just go about your business as you normally do, but instead of prescribing an antibiotic for 3 days, can you sell a free x-ray voucher? In a sense, can you replace that habit that you have with this for these sorts of patients? It was meant to be a replacement, but you can't guarantee that it was a replacement because there's no records. And there's this record, but I can't verify it. It's all just, the pharmacist's rights. Yeah, absolutely. And then we kind of recruited 105 pharmacists in a stepwise manner, right? We wanted to make sure, if there were any tweaks in the beginning, we wanted to know. We also wanted to make sure that the pharmacists that we recruited could serve as their own controls. And so we picked 3 city blocks. This was a purposive sample based on their proximity to one another and based on the fact that they were serving primarily lower income clients that we felt would more likely have this trust with the pharmacist as opposed to other more affluent areas of the city where patients would much likely just go to a doctor directly. And then we randomly sampled 15, 15, and 75 patients, pharmacies in each of these 3 blocks. So, some results finally. Here we have, over 18 months, we have not yet converted these into pharmacist month data, which is what we're in the process of doing. So we clearly don't have any significant tests involved, statistically significant tests done as yet. But over about 18 months, 105 pharmacists overall delivered 1,529 referrals for an x-ray, of which 86% of them were completed. Of these, about 60 to 40 resulted in an abnormal versus normal result of an x-ray. The doctor referrals, there were about 840 doctor referrals. Most of them were post-completion of the x-ray, but about a third of, maybe 20% of them were direct doctor referrals, so they did not get an x-ray. The pharmacist decided to just send them straight to the doctor. Of these, a very, very high proportion were completed. So this sort of slide shows, if nothing else, that at least whatever the pharmacist is saying, the patient is very likely to agree to that. In the control period, which is basically the same study pharmacists who were monitored for pre-intervention, where they didn't have this option with them, but only were able to refer patients directly to the doctor, we had a pretty low turnout, and of which 81 referrals were completed. And then for the broader sort of cohort of study pharmacists, of non-study pharmacists that were engaged in the UATBC program, again, we had pretty low rates of referral. Yeah. Yes.
The intervention period included your intervention. Did it also include all those other UATBC interventions currently?
No, this is the UATBC. Sorry, what do you mean?
This intervention that you're doing is nested with other interventions.
Yes.
During this intervention period, does that include your intervention and all those other interventions? be sure that the improvement, or what seems like an improvement, is attributable to your intervention and not possibly some of those parallel interventions?
Well, this I think helps us to do that, because this is during the control period when they were not recruited into the study. This is what happened. Do you know what I mean?
Control period, your intervention was
Yes.
not implemented, but those other interventions.
Yes.
Okay.
Absolutely, everything was gone. That was sort of the norm for these chemists. Yeah.
Sorry.
I wanted to just get through the end if possible, but yeah.
Just a really quick question. Were you at all, because you have this selected group of pharmacists that engaged in your pilot, and then you have the bottom. Are you able to kind of tease out what your selected group did before versus now?
Right. So this is sort of the before, pre-intervention. No.
Oh, it's just
This is the control period of the study cohort, just these 105. Sorry, I should have probably put a line there. And then this is the full 700. Yeah, and that was the reason why we did this stepwise, so we could capture this data before. And then for this, actually, we have data for the 3 months before they started as well.
Sorry, one more question. Did the UATBC, like all the training was done and things just carried on as normal?
As normal,
There wasn't
yeah.
any, like,
No, as normal. Nothing changed really. Nothing tangible.
EBC is not as big as
No, yeah, it's the government study. No, it's not. Yeah, that's a government program. It's a public-private program that's supported by the government.
is that like designed? It's a research study, or is that
It's a program. It's a program. Yeah, they're actually in the process of transferring to the government. So the call center will support the government for the first year. So that's sort of happening. The UATBC program is pretty much going to be the standard now in the city. Yeah.
Paid for by the government.
It will be. It will be. Right now it's paid by Gates Foundation. And basically, I think this first year, there's this in-between sort of, they're in the process of transition. So WHP still provides support. But the next year onwards, it'll be fully by the government. Yeah. So this is how many case notifications we got. We got about 255 cases, of which 251 are on treatment. The remaining 4, they're either diagnosed with MDR TB, so we didn't include that in the study, or they moved on to get a sort of an out-of-network doctor. They went to a different facility. In the control period from the patients who were referred, 28 were identified with TB. And then from the broader UATBC cohort of all the patients who were referred by a pharmacist, 55 cases of TB. You can see the rates of microbiological testing generally low in India. So, and Patna especially, about 56% and 50% in the control, and you're seeing about 75% in the intervention. Confirmation, very low all across the board. Certainly better in the intervention period than in the control period, but still clearly suboptimal. And then we have some details about the tests. We can get into that later if you're interested. Estimates of diagnostic delay. These are based on median values because this is not, I wouldn't say this is a representative sample. So days from symptom presentation, so based on what was written on the vouchers, we were able to calculate a median of 30 days between when the patient first started having symptoms related to TB and actually went to the chemist or the pharmacist was about 30 days. Days from pharmacy contact to TB notification was 5. So this is really like great, I thought. The amount of time that it took for the pharmacist to sort of, kickstart that diagnostic process.
How's the MPH?
Yeah, sorry, that might be.
It might be switched.
Yes, you're absolutely right. I have switched it. I'm sorry. Yeah. Clearly, this is not my forte, but yes. I'm like, whatever. And you can see I don't have any decimal points anywhere, which some of you might be a bit nervous about. I may not trust my figures, but I said, who cares if it's 73.1 versus 73.3? Is this actually going to make a difference in policy? No. So anyway, please pardon my sort of, quick and dirty statistics here. Pharmacist participation, at least 77 pharmacists referred at least one patient, like to get an X-ray or doctor referral through this program. At least 34 pharmacists referred more than 10 patients over the period of time that they were in the study. And the referrals resulting in at least one TB case notification, so at least 57, so about half of the cohort was able to refer somebody who eventually got diagnosed with TB. The overall yield, basically, of all, if you were to count all of the referrals made, both, the 1,500 or so X-ray referrals and the 144 direct doctor referrals, which did not get an X-ray, it's about 15.2%. In a sense, 1 out of every 7, 8 people who get referred will end up getting diagnosed with TB. of course, all in progress. Comparative analyses, we're going to really convert all of this to pharmacy month. Because of the stepwise recruitment, it's hard to really make a fair comparison between the pre and post. But we're getting there. And we really want to do some gender analyses. I think that'll be quite interesting as well. Pharmacists are all men. All men. So that's very easy. It's all men. And this is not unusual at all in most of India, I would say. The women pharmacists are working at drug companies for the most part. They've done a degree. So we did do a qualitative evaluation, and these findings are also being analyzed right now. We ran some focus groups with all of the pharmacists to understand what are their barriers and what are sort of the things that would encourage them to participate in this sort of a project going forward. We did some in-depth interviews with patients, doctors, and chemists or pharmacists who were not so active to understand what were their issues as well. And this is just like a quote that I like that came out of the first focus group, where they felt really pumped up that they were sort of engaged and sought to engage in TB care beyond just being this pill pusher. Some of the ideas that came out of the first few sets of focus groups, which we really have analyzed, we haven't gone on to analyzing the others, but we did spend some time in the first couple of focus groups, and it sounds like the study model is quite acceptable. Credibility, the pharmacists felt that their credibility and trust in the community was raised as a result of this intervention. We were a bit nervous that this would sort of interject with some of the ongoing relationships and networks that the Indian public healthcare system is built, private healthcare system is built off of, but the relationships with the labs and doctors were perceived to be quite stable and good. Patients clearly are listening to what pharmacists are saying, good or bad, they're listening. There was improved microbiological testing, but of course very low rates of confirmation still. They all were very excited to keep working on this, but I'm not sure. We'll have to see if it's worthwhile. Denominator. This is impossible to know. How many patients actually came into the pharmacy who could have been referred by the pharmacist and did not? Right? We really have no idea of knowing this. Documentation for pharmacists. These guys are working. They're seeing 20, 30 patients every hour. There's no time. There's usually no helper. Sometimes there is a helper. They're getting calls on the phone. It's very, very hard to ask them to document. Even just like a check mark. Just tell us like how many patients you saw that had these classic TB symptoms and that could have been eligible for some of these referral mechanisms. But it was very, very hard to capture this. We did sort of consider placing an anthropology student there and just sitting beside, for like 2 weeks at a stretch and counting the number of patients like on a clicker. So, and there's no records. There's literally no records. We don't know anything about OTC sales except for what pharmacists shared with us in the focus groups. We really don't know if this made any dent in in over-the-counter sales. What's that? Yes, absolutely. So that's a really good point.
Done already and published, but that still doesn't tell you how many people show up to pharmacists with TB symptoms in an average day.
Why can't you just have some, I know you're laughing at it, but we do these care measures all the time in terms of how much time people are spending on activities. Why don't you just have somebody sit there for a week and count?
But you don't know if that patient was actually eligible, right? It's not just any patient who comes with a cough. You have to listen to the conversation to see, was his cough really over like 2 to 3 weeks? Was it? Oh my gosh, no. And you won't. It would be impossible. You'd be sitting there like this is not.
Maybe we should just do it.
We could try. Ben actually, one of the epidemiologists, recommended it. So what we did end up doing, kind of asking pharmacists, in a week, in last week, like how many patients came in. This is before we even started the study. We asked them how many patients did come in and came to your shop with like this chronic cough. And they said, 10, and then some pharmacists would say 5. But the next time you go back and ask them this sort of same question, they'd say, 7, 20. So it just changes. So the self-report sort of system recall is not really working. But if we had a better way of knowing the denominator, I think maybe it would work to set up somebody there and listen and recall. Yeah, okay. Now we're getting into a lot of ethical yeah. Anyway, there's a very, very high pharmacy workload, so the vouchers were not particularly, we had them very basic. As a researcher, I was sort of remiss that we couldn't collect more data at that point of interaction between the chemist and the pharmacist and the patient. Sorry, I refer to them as chemists because in India that's sort of the term we use. There was pretty inconsistent post-X-ray follow-up. So a lot of patients, about 67% of the abnormal X-rays were finally referred to a doctor, and about 40% of patients who came back with a normal X-ray were referred to a doctor. So it's great. I'm very happy that even normal X-ray people were referred to a doctor, but I would have liked higher numbers of both. As I mentioned before, low microbiological confirmation, and the system of doctor fees. So pharmacists are referring patients to doctors, but in the private sector, they still have to pay the fee. That piece is not being covered by UATBC or any other program. Take-home messages, I think these are sort of the three big things. Pharmacists are willing to participate in a TB program, so we might want to sort of liaise with them. They are potentially participating beyond consent. Everybody sort of nods to consent, but do they actually do the work thereafter? The business model seemed to be quite acceptable. They were able to identify TB cases. So about 15% of patients referred by pharmacists were eventually diagnosed with TB. I would love to see a comparison of this and what happened with all of the doctors and AYUSH practitioners. How many patients that they referred for these diagnostic and screening tests were eventually referred diagnosed with TB. So we're working on that. They could help to reduce diagnostic delay. It's too early to say. I'm not firm about this, but if you were to add up the 30 and 6, it comes to 36. That's the kind of math I like, compared to systematic reviews that have sort of showed 55 days diagnostic delay, and these are both based on median values. A lot of contextual barriers exist, clearly, but you can't change that. That's the Indian context. That's the context you're working with. So I think we just need to find ways to work with it. Ideally, sure, every patient should go to the public sector. Ideally, yes, go get a sputum test before you do anything else. But that's just not how it works. So you got to work with the system. I think a collaborative approach was really, really key to the study fidelity, to making sure that as far as possible, the implementation, the study was implemented as we intended. A participatory approach was key, like the situation analysis, going and touching base with the pharmacists, giving them feedback, having refresher sessions where we'd serve them lunch, of course, and local team monitoring was key, building on the existing network. Without that UATBC program, without the public-private project already in place, this would have been impossible to do. The call center made things so much easier, right? And made it a lot cheaper for us as well. And I think our multidisciplinary team is going to be really fun, like having the social scientists, clinical epidemiologists, physicians, Sophie, the biostatistician. It will be really, really exciting to see what comes out of this. Can this transition from pilot? I once heard Mario Raviglione saying in India that India is the land of pilot projects. So when can we actually take this to scale up? As a qualitative researcher, I think every project has to be contextualized to the local context. So I'm okay with the pilot piece, but I think, can we sort of move this forward? The UATBC project, as I said to Olivia earlier, it is transitioning to the government program as we speak this year. I think disseminating this sort of work is going to be key to really see, does this sort of idea gel with the local stakeholders? And I think we could potentially open up new avenues in terms of a smart app if more and more pharmacists in the community start to use, the fancier, newer firms. And of course, I think this can really inform what we do in other contexts, right? Pharmacists are the go-between for many, many conditions and in many, many contexts, not just in India, in Canada as well. So how can we capitalize on that to sort of enhance the pathway to care? Some acknowledgements. Thank you to everybody who's put together some of this work. I was on the phone with some of the people at WHP this morning, so I was like, can you just send me this one detail that I don't know enough about? And they're so spot on in getting back to me and really, really engaged in the programs. That really is helpful. So thank you. That's
That was a great doctor.
Thank you.
So in terms of scaling up, assuming that everything holds up, when you say scale up, does that include that? In some ways, there was that financial incentive that otherwise would not be there.
Yeah. Absolutely.
Totally working in a business
right.
model. So scaling up, would that include, a government funded incentivization?
It's possible. I'm not sure what's going to happen because this was a pilot study, and in the new government program, the private doctors are continuing to get a small incentive. I think they're scaling it back a little, like by 50 rupees every one of them. And WHP, the World Health Partners, who actually ran the program for the first 4 years, has scaled back the incentive. So what doctors were starting to get, $3 for every referral, and they've scaled back to $1. So over the years, and that sort of worked as a good way. So in the beginning, give more to get them all in, and then sort of slowly come down. This sort of Walmart approach of with volume, hopefully we'll still make some money. And so that could be a potential way to do it. The PPM models are also being implemented in, not with the chemists, but with doctors and Ayush practitioners are being implemented in Bombay as well. There are no incentives given there. And it is working. So if we were to do something like this in Bombay, it's possible that we can get away without an incentive. We'll have to see. So I think context is quite key. Yeah.
So, Ben, just to clarify, Global Fund just paid India $40 million US to scale up these projects across the cities. The pharmacist piece that we've developed is obviously not in the plan, but hopefully if we can publish this in a good journal and convince people, then it could get buried within this Global Fund. But the public-private engagement of the bigger nature that she showed is being scaled up to 30 cities, which is pretty dramatic. So Global Fund is the one paid for it.
And the initiative into which this is embedded, who designed that? Ambitious and impressive. Like the government, which is involved.
I was, and the Gates Foundation.
I mean, I love it. Pharmacies, call center.
Call center is better than the system here.
It's awesome. It is amazing. These women are just amazing. And they dominate. There's like about 20 women and 4 men. And they just dominate. And they're amazing on the phone. You just see them going, it's all done. The forms are filled out.
But for the x-rays, they go anywhere where there is an x-ray available? There's not a designated center?
They've engaged a lot of labs. So that's sort of typically where they get the free x-ray. If they want to pay out of pocket, they can go to any lab. But if they want it free, which most patients do. And so what we also did is we piggybacked on WHP's networks. So what happens in India is, my aunt owns an x-ray shop and or a lab, and my, husband's fiance owns this, not fiance, but you know what I mean. This person owns that. And so it's all this network that's connected through social sort of networks. And we piggybacked on that. We're not trying to disrupt it. We're trying to just work with it. Yeah.
In terms of the scaling back or scaling up, can you give us a sense of what Patna is like in terms of its setting? I mean, did the actual intervention take place in an urban area?
Yeah, sorry, it is an urban area that we worked in.
How many pharmacies? Can you give us a sense of what pharmacies? How far do people have to walk to rural area to get to a pharmacy? Would this work there? Is that there's a large number of people in those kinds of settings.
Yeah. It's so interesting you say this because when we started to develop an idea for this project, WHP really wanted us to work in rural settings because they thought that's where the pharmacist-patient relationship is even stronger because their patients do have to walk quite a ways to get to their provider, to a doctor or an Ayush practitioner, but pharmacies are actually more common in comparison to a doctor or an Ayush. It's like a shop. It's a shop, and also it's just a shop. But they're thought of as being cheaper because you don't have to pay a fee and they're very accessible. So that's really where they wanted us to start implementing. But their program that we wanted to piggyback on was in the city, and so we said we want to be in the city.
How would you do this? Let's say you get money and you can scale this up. How would you implement this, or what kind of pilot project would you envision to do next in a rural area?
Yeah, I think I'll be quite honest in saying that this sort of a project will work in places where you can capitalize on that pharmacist-patient relationship. And that relationship is not necessarily going to be very strong in an affluent area. Those people are probably going to just want to go straight to their doctor. Right, so in a poor rural area, I think it would be about really sensitizing pharmacists to these sorts of symptoms or whoever's sitting in the pharmacy to what classic TB patients look like and sort of working with their mindsets. I think having this collaborative approach where they're very actively involved in how to sort of do the intervention and making sure that the tools that we ask them to complete and use are really friendly to how they work is key.
Virtually no X-ray machines of it.
And so you have to dispense with that piece of it, right? And what about doctors? Because they're referring to doctors, right? Not kind of...
No, formal doctors, like qualified doctors.
So how far is it from some
Far, absolutely. Yeah.
There are other barriers.
Absolutely. Absolutely.
But there's almost villages. It's not villages that really no, but honestly, so
yeah.
I gotta even know. I guess there's different interventions that will
Yeah.
What are other symptoms that people have in addition to TB? So they come to the healthcare system with a cough more than 2 weeks, whatever it is. So what are the other,
What's the differential diagnosis?
yes, what's the differential diagnosis, and are the people helped with that? I mean, I understand your focus is on TB, but what happens to the patient who doesn't?
Yeah, you still refer if it's a cough that's more than 2 weeks, you'd still refer them to the doctor because clearly something's going on. And that's why it was clear that it needs to be unresolved cough. So if it's been below 2 weeks, before 2 weeks, if a patient comes to the pharmacy, he is usually sold some medicines to help alleviate it. And if it's not resolved through that, then you should go have follow-up, regardless of what the X-ray finding is. But the differential diagnosis would be any like respiratory illnesses that I hear. Similar sorts of things.
With respect to a positive.
Yeah, so the UATBC program does do some follow-up, but our study sort of ends at the point of case notification. But if the patient is funneled into the UATBC program, which they are, then they have adherence support for the patients, and then they usually get a visitor, like a visit, in the first 2 weeks of treatment by somebody, and at that point, that individual, like I say a field officer, will do some basic assessments of the home and who's living there, but it's not the standard that you would expect. Yeah.
And where do they get the TB meds from?
Back from the pharmacist. Well, they can go to any pharmacy, but yeah, absolutely. Yeah.
And they can't dispense those in theory without.
Right, and also in practice, it's interesting because Madhu's done use the standardized patients to see what pharmacists do, and they'll give every kind of drug, but they actually don't give TB drugs, except for Cipro, which is not really a TB drug, but yeah. So that's the one thing they somehow feel anxious about dispensing over the counter, which is good. Yeah.
Well, really interesting.
I wanted to ask, who's the clinician in this room? Okay, great. So what do you think about giving a pharmacist this sort of, this power or authority to give an X-ray test? Yeah.
Pharmacists are getting vaccines now.
I don't even know how much healthcare advice is even like. People go to the pharmacy, ask them all the questions,
Yeah.
recommendations for over the counter things, but we don't know what the denominator is.
Yeah. Yeah.
But access to care, I mean, I know on a different scale is an issue. And access to primary care is an issue. People sort of seek informal pathways of care.
Mm-hmm.
And when you were showing that graph, getting diagnosed with TB, I don't know, I think I could draw a graph like that in Montreal.
Yeah. I think you're right.
For different reasons, and maybe for different levels of care. But,
Yeah.
Pharmacist problem here, I think, is that the incentives for selling homeopathic medications don't have any, don't require any evidence of efficacy, are very strong. So, I mean, a lot of people call it patients, but then people will go to pharmacists and get their advice about finding very expensive over-the-counter homeopathic medicine, and of course that bypasses the healthcare system, but not necessarily in a good way. I think the financial effect is such. What pharmacist would cut off his or her own financial nose or his or her own boss's nose?
Yeah.
I'm saying this stuff doesn't work. Why do you spend $30?
I do. I say it to all my patients or clients. It doesn't work.
You're implementing this through a system that seems like it's already up and running. People there rely on the pharmacist.
Yeah.
The financial incentive.
Yeah.
Driver to engaging the pharmacist.
Yeah, absolutely.
My biggest worry is, as much as we think that this is impactful, I'm convinced that they're using these vouchers on a fraction of the people. And not just in this project, across all of these public-private partnerships. You give them vouchers, they're holding it.
To do what?
I don't know why they're holding it. In Mumbai, we've given them
their own
expensive gene expert vouchers.
financial
It is a very complicated, even our simulated patient studies, we know they have vouchers, they underuse it. They cherry pick only a few people to push them through these free schemes. For most people, they do whatever they normally do. And this underutilization of vouchers is a phenomenally interesting topic in public health.
And
Even when you give them, not just that, it's busy, of course.
Yeah.
There are all sorts of, like she was saying, there are all sorts of interesting established kickbacks and relationships in private practice that suddenly this global health intervention of somebody coming and dropping vouchers disrupts. Or they're doing some means testing in their head.
Yeah.
Yes.
You look like the
Yes.
poorest of the poor. Only for you I'm going to give. When we said give it to everyone who's eligible,
Yeah.
we will only pick a few that are either saying they're desperately poor or they want to have some relationship with them. It's so complicated at the time. Every single study tests vouchers, drug vouchers, consistently underused in all the cities that we work. What they're doing with all of them and holding them in their drawers is beyond our understanding. We haven't cracked the problem.
It's not fun giving that. Like, I assume that telling a patient or a patient being told it's just take this cough syrup versus this might be not fun. And also, did you see like how much time? I know that you made the voucher as brief as possible, but even like, having to explain to someone like, oh, this might be tuberculosis.
Absolutely. Absolutely.
Yeah.
So we actually told them not to mention TB until the point of the exclusion criteria piece, where they would mention other sort of illnesses like, do you have like asthma or like the local, TB? They bunch it in with a bunch of other illnesses to make sure that this patient was not already diagnosed with something or has a history of that. But we didn't actually mention that this is for a TB test. It's just a screening test for any kind of.
Like the average time of an encounter where it ended up not triggering a voucher versus triggering it?
Oh, the difference, no. But I will say that most pharmacists in this setting are probably speaking to their patients for no more than a minute.
Sure. Right. But I was in terms of gauging the incentive.
Uh-huh.
I personally think
Yes, and so I think the qualitative interviews will be helpful.
Why isn't that taken up more? Maybe they've done the integration and they said, well, yes, you're giving me $3 or $1 for
Yeah.
this, but actually I could see sort of 5 people who don't trigger a voucher in that same amount of time. And it actually
So I just want to say, after speaking with the chemists, with these pharmacists, literally the $3 is not making any difference in their lives. These guys have so many customers, they are not interested. Like for us, we feel as researchers, $3 incentive, that's what's going to make them change their decisions. It is not making any difference. They don't care. Maybe the $4 they care, but the 4 plus 3 now it adds up to something substantial. But they're not interested in the $3. I mean, the whole study, 18 months, 105 pharmacists, the total incentives we've given out, and remember it's stepwise recruitment, so only about 30 of them actually participated with full 18 months has been $4,000. All incentives included of everything possible. So it's really like. It's not that much of money compared to what they're making in their gross sales in general.
The 2 examples like the specificity of that impact. I mean, I go to Calcutta. I normally don't have asthma. I'm living in the air is thick, and so I just wonder if they're making that. Ascertainment. I've heard that lady Lee's for years.
Absolutely.
Forget it. I'm not sending her. I think that might be.
Yeah, they kind of make this decision right there. Does the patient look? How disheveled do they look? Are they going to go to the next pharmacy like as soon as I suggest something out of the normal picture? If I suggest.
The other option is just to advertise directly. You have a conference. Kind of get there.
So that was definitely something that the pharmacists also have said in more recent focus groups. Like, can you have literally a loudspeaker going around saying this? So we had posters that said that at the pharmacy shops. But there's like 1,000 posters at the shop, so people don't always listen. But they did say, can we have like somebody just announcing?
Or as you're waiting in line to see the pharmacy.
Yeah.
Sometimes.
Yeah.
Pick up about.
There's no line. There's no line. It's just a herd like this. Yeah. Yes.
I think we should probably, after this one, break into the patient. I just get a lot of
Yeah.
Go ahead.
I was just wondering I know nothing but
trust because it kind of goes away, sort of that level of like, I can take care of this.
Yeah, so I will say the pharmacists, at least as part of our study, and we did sort of, as I said, it was a purposive sample of pharmacists in these city blocks that were relatively poor. They're quite committed to patient care. I mean, but they do want to balance their business, like they need to make money. But I wouldn't say that they are sort of, I don't want to say malicious, but they do want to do good in the community, and engaging in them in this program did sort of help in that. The ones who didn't participate, what's coming out of those interviews, again, it's very early analyses, is either they didn't have patients like that because they were placed in sectors where, near to cancer hospitals or different types of facilities which would see more different sort of demographic and types of patients with different sorts of illnesses coming in, like stomach problems or things like that wouldn't necessarily trigger a referral voucher. But they seem quite committed. Time, like workload is huge. Who has the time? There's so many patients to come now, even if it's a 30-second form to fill it out. Often pharmacists would refer patients to a doctor. We just don't have the documentation of it. So, yeah. Thank you. Thanks very much, Michael.